Hello all, as you're filtering in and your audio is getting set up. I hope you can hear me, hear us. We're so excited to have you joining us today. Thank you so much. This is the 13th Health Equity and Social Justice Conference. It's our first virtual one, so we certainly appreciate your patience as we figure out some of the technical aspects to it. But we're so glad to have you here. We've got a fantastic roundtable discussion today. So we have the title of this session is We're All in This Together, Evaluating a Community Health Worker Initiative. And we're joined by Banita McCarn, of SUI, Sinai Urban Health Institute, Kim J, also Sinai Urban Health Institute, and Angela Eastlund of the Health and Medicine Policy Research Group. I'm going to admit a few more people real quick while if we want to give them just a second to filter in.
Great to see some familiar names here. Hi, Kathy, some former coworkers. And hi, Jackie.
Great. And we have, let's see now. Yes, we have everyone coming in. So exciting stuff. Just a reminder, if you would keep your microphones on mute unless the hosts ask you to take it off and ask questions. Otherwise, if you just keep it on for the time being. If you do have questions, feel free to put them in the chat. I'll be watching throughout and I will be cutting in to ask questions of the presenters. So feel free to be active. If you're comfortable with having your camera on, we'd love to see your face. If not, we understand. And with that, I will turn it over. Thank you.
Thank you, Emily. So I wanted to start out this afternoon, I guess it is. With a quick reminder of the chat box that's on the bottom of the screen and the microphone on the far left to mute and unmute. So there's a lot going on right now. Which picture best describes how you are feeling this afternoon? Had a full morning of sessions. We have a lot going on in the world right now. How are you feeling? And just turning over here to see the chat. A, B, C, D, E, F.
Banita, do you need to share your screen?
Oh, I'm sorry. I thought I was. Okay, sorry about that. Thank you.
Got lost.
Okay.
Yeah.
Thank you. All right. Which best describes how you're feeling? I'm gonna just look at here at the chat. We have some C's, some E's. C. So some happy people, some very happy people. F. All right. Great. All right, I have another question for you. So if you go to menti.com, use the code 6134213, no spaces are needed. What role do you have at your organization? You kind of want to get a sense of who is here with us today. And here it is again, the code 6134213. All right, we have a diverse group of people with us today. Some program evaluation people, director, an analyst, VP of programs, independent consultant. Anyone else? All right. Okay. So thinking back 7 months ago, March 11th, 2020, what do you remember from that day? And add your response to the chat box here. Yeah, the COVID shutdown, working from home, lots of chaos, rising cases of coronavirus. Yep. All right. Cases increasing, working from home. I was taking a look at some of the headlines from that day. That was the day on March 11th, WHO declared the coronavirus a global pandemic, and the day after, the US limited travel. On that day, Tom Hanks announced that he and his wife, Rita Wilson, had tested positive for COVID-19 and were sequestering themselves in Australia and to recover. He posted this on first on Twitter and then on Instagram. The Dow plunged 1,400 points, ushering in a bear market. Coronavirus, the first reported cases were on Capitol Hill. So it's a pretty big day. And at that time, we had just reached the 1,000 mark cases of coronavirus in the US, with just over 1,000 cases detected and confirmed in the US. And then that following Monday, on March 16th, caregivers, Kim and I at SUHI and our colleagues at HMPRG and places across the country really had started to work from home. So I tell this story as it sets the context for what we're going to be discussing. So I'm going to hand things over to Angela, who is going to give an overview of our project.
Great, thanks, Banita. So just to give you some framing, I'm going to go a little further back in time. So back in 2017, Community Memorial Foundation and Healthy Communities Foundation in the western suburbs of Chicago collaborated to fund models of healthcare delivery that utilize community health workers. And thus, the foundations wanted to improve access to care and grow the healthcare workforce. And following an RFP process, 5 organizations with diverse missions and audiences and employing 11 CHWs were funded and incorporated into a learning collaborative by which CHWs and supervisors engaged with one another and with content experts to strengthen their skills, referral networks, and knowledge. So Health and Medicine Policy Research Group, a policy think tank with a long-standing commitment to CHWs, is the project coordinator for this program, and that's my role. And we serve as the backbone of the work and a key convener throughout the pilot process. And Sinai Urban Health Institute, my colleagues here today, was tapped to serve as the evaluators and trainers for the pilot project. And they're, of course, going to share more about their role later on. But the overarching goal of this project is to improve access to care and advance health equity for individuals living in the western suburbs of Cook County. And so the 5 organizations that were selected from the proposal process to be a part of this pilot were Mujeres Latinas en Acción, Aging Care Connections, Healthcare Alternative Systems, Beds Plus Care, and Alivio Medical Center. And they all serve a very diverse population and have different focus areas, of course, as you can kind of hear in their names. And they serve in total 18 community areas, a population of over 171,000 people, and cover over 42 square miles. And of course, it's also a diverse and changing population as Latinx families move from the city of Chicago to the surrounding suburbs. And so what the key outcomes we are looking for in this initiative were the overall objectives of increasing the number of residents reached within the target service areas, increasing the rate of referrals to other services, increasing the number of referral organizations to strengthen the referral networks, strengthening organizational capacity for delivery of services, participating in all learning collaborative trainings, and developing program-specific outcome objectives as a result of the learning collaborative activities. So that's the basic framework. I'll pause there to see if Banita or Kim want to add anything before we move on.
Nope, I think you covered it.
Great. So I can pass it on to Kim or Banita.
Kim will talk about our learning collaborative.
Good afternoon, everyone. My name is Kim J. I am the Senior CHW Consultant and trained with Sinai Urban Health Institute, and also one of the lead trainers that was on the program, the pilot program, to do the learning collaboratives for the 5 organizations that were selected to be a part of this particular initiative. I will say that one of the most amazing things about getting this learning collaborative together was to make sure that the organizations who participated were on the same sort of playing field of knowledge and understanding of what community health work was and how they can do that most effectively for their individual organizations. Everybody had their own needs, their own individual challenges, but still there was a common thread, how we were able to weave them together to make sure that they were able to do their roles effectively, but also lean on each other for support with other resources they could possibly need. Now we would get together every other month. Well, maybe I'll back up a little bit. We actually implemented the initial 40-hour core skills training, where we gave those that were hired to do the work, the community health workers, the foundational core skills that were needed to actually be effective in their role. Some of these training modules included motivational interviewing, social support, ACEs, which is adverse childhood experiences, cultural humility, cultural competency, and other presentation skills that would be helpful in this role that they would be doing to reach community members and also to be effective in their position as a community health worker. Within that, we also layered on what we would call our learning collaboratives. And that was a way for all the community health workers who are part of this pilot to get together, share their best practices, share their challenges, and also together discover answers to some of the things that will come up in their daily role and even in their work. But one thing I will say that these learning collaboratives have served as was a support system as well for the people who were the community health workers for these organizations. They were able to, especially during the time of the pandemic when things began to shut down, they were able to lean on each other. They were able to provide that social support for one another and even share their own fears and their own challenges. And then as a network, we tried to work through those things to not what we thought as the organization leading it, but what they felt was best for them. The learning collaboratives, again, helped to enhance skills that they had and also to layer on those that needed a little more reinforcement. And these learning collaboratives met every other month. And we met for 2 hours. And again, the first portion of the learning collaborative would be to talk about those challenges and triumphs. Then the second part would be official trainings to add on to or reinforce some trainings that we already implemented or some that the community health workers expressed an interest in. We also emphasize the importance of even telling their qualitative stories about the work that they were doing, because to me, the best way to know how any kind of program or implementation impacts someone is to actually hear their story and to hear it firsthand from the community health workers and even their client population that they serve was very impactful to let us know if what we did was actually good, if we did a good job of providing the services and then empowering those community health workers to do their role. As I said before, this learning collaborative model provided support for these community health workers independently, but also provided them a way of leaning on each other's services because they were independently different. They had, senior services, mental health services, different things that dealt with domestic violence abuse. So they all had their different umbrellas, but they were able to support each other within this network. So again, I will pause here to see if anyone has any questions regarding that portion of the particular pilot that we can answer for you. And if there be none, I will go ahead and pass it on to Banita.
Thank you. So one of the ways that we had framed our evaluation was to make it really participatory. And that meant engaging supervisors and CHWs in the piloting of our data collection tools, but also in the creation of them. We also engaged our funders, who I see one of them is here with us today. So thank you for attending, in the overall evaluation. And then we also created clapping is creating additional tools that were in response to feedback that we had from our CHWs and supervisors. We were also made a lot of modifications then in March, where our CHW activities and our learning collaborative went virtual. And we provided a lot of technical assistance then on what that looked like from a data collection perspective. So I want to launch into our discussion now and talk about what ways have you engaged and included participants in and also in stakeholders throughout your programs and evaluations. And this would be a time for you to unmute yourself and join the discussion.
Banita, I'm the kind of person who really doesn't like a lot of dead air. So
yeah, go ahead.
If we could, if I could just really speak to again, even the pivot that had to be made when we first went on lockdown for the community health workers, how we had given them all this great knowledge and tools to say how impactful they would be to the community and how important their role was to all of a sudden have to change and go to something that we had not totally imagined or thought would be a part of the process. And how when we initially went home and we began to set up these virtual platforms to be able to still connect even with our community health workers first, we had to put them at the forefront of this whole endeavor because they were the catalyst, they were the piece that would be the connection between the organization and the community. And we had to indeed make sure that they were okay. So our first line of defense was to do those check-ins with them via our already established platform or those learning collaboratives and those community kind of sessions, and to speak with them to see how they were. How are you doing? And a lot of them had the same fears that we all had. What is going to happen? How is this going to move forward? And even as an organization, we were like, how can we be impactful if now being in front of clients we can't do, we have to be remote? How can we still be impactful in our role? And we had to figure out how to do that. But again, at first, our first line of defense had to be to connect with those community health workers. So if they needed to cry, we let them cry. If they needed to scream and yell, we let them do that. We also gave them tools of how to practice self-care to make sure they took care of themselves. And then as we regrouped, we start to figure out as a group, how could we now connect with our client population now that we're remote? We had to even add on trainings on how to use Zoom platforms, on how to start being more virtual and using their speaking skills in order to connect with people. And when we started to really embrace what the new reality was, people start to feel comfortable about still saying, you know what, we can do this. We can still reach our client population. We can still make a difference in our community. It's just going to look a little different. So, and even in doing that approach, we had to really involve everybody that was connected to the program and the pilot, because they had to understand that right now, our key players in this are having to make a really big adjustment. And then how could we support them? And with that, we were able to, again, give them that empowerment they needed to definitely do the role and the work that was ahead of them, that still is able to impact the communities and even be a beacon for the organizations that they work for, to let them know we're still here, we're still active, and if you need us, we're still available to help and do the work we've been known to do. So I'll just add that, and if I would hope somebody has a comment or even a question to help further along the conversation, it would be great.
I can add something. I don't know if anybody else is going to, but one thing I've realized through a lot of this work is there's really two elements of moving to a virtual platform that are a bit challenging. One is, does everybody have the technology to fully participate? So if we're, I know like right now, not everybody has their cameras up, but if you're on a meeting where everybody has access to a camera and can see people and you're the only one that doesn't, it's really hard to engage in the same way. I've been in situations, my camera isn't working, and it feels, you don't feel like you are getting the same weight or you get to voice things the exact same way. So for folks that either don't have computers with cameras, don't have phones with cameras, or have internet problems. You know, internet to some degree, this is a whole different topic, is a social determinant of health, we're realizing. And people don't have connectivity widespread, and it's very limiting. So some of it is about who has the technology and how we can support our participants, our community health workers, our staff to make sure that they can engage. So I'm curious for others on the call how you facilitated that. But the other thing, which Kim, you did start to touch on, is you may have all of the technology, but you don't know how to use it. So, you know, some people are, we're clearly getting more comfortable with it, but we're still having problems. Hello, can you hear me? Can you hear me? Or, you know, I can't hear you. What's going on? So I think there is another element that is kind of just capacity building around how to use Zoom, how to use meeting, WebEx, whatever it is, troubleshooting. It's really easy. I guess it's easier if you're on the phone, it doesn't work, maybe you hang up, you kind of know what the problem is, but sometimes on the computer, like you don't know what's wrong, and none of us, I don't know about you all on the call, I'm not an information technology person, computer programmer. I don't know what the problem is half the time. So figuring out how to build capacity for, you know, are particularly individuals who have never before had to use technology, now all of a sudden are expected to participate in that way. So I'm curious how others have engaged with those challenges.
And presenters, before we move on, sorry, that was a fantastic answer, but we have a question from the chat. If you would please repeat the question. Oh, Banita, I think you might be muted.
Yeah, it was, the question was, how have you involved and engaged stakeholders in your evaluations and in your programs in a participatory framework and model?
Hi, my name is Mariana Martinez. I work at Rush Copley in Aurora. I have a question. How did your community health workers, or did you, when you're working with the community, if they don't have an email address and there isn't necessarily a way to connect with them and you're trying to teach them how to do that, did you partner with like the libraries for them to try and like create an email address, or did you create like a video tutorial and posted it? That's currently kind of the conversation we're having with some of our support some of our programming and community programs is how do we connect them? A lot of them tend to have to wait till their older children are home and their children can help connect them or leave them step-by-step instructions, and fingers crossed that they're able to connect. But just some feedback, maybe how your community health workers or yourself kind of connected with the digital divide that exists right now with some of our community members.
Actually, that was a very creative process, and we really had to take a lot of different angles. It's like, throw it all in there and see what sticks. People were very familiar with Facebook and how to get on Facebook. So we introduced them to that model. People were very familiar with texting, and even if just an intro to texting, just to get them to know how to do that. But also, if we had to create email addresses for them, we really would take them through step by step and take them through the process, and let them get familiar with it, because again, it was a learning curve for a lot of people, because now we have to do everything virtually, and we need to know to some degree how to do that. So the same kind of approach that the community health worker knows that community-based connections make, that's the same route they took. So if it meant, well, you know what, maybe I can run down to the library. I've had community health workers who actually met people on their front porch and actually provided them with information and documentation as to how they can do things, or even answered questions for them. But again, I think the most user-friendly platform that everybody was familiar with was Facebook. And they created Facebook groups, and they were able to go live with them on those platforms, or even just connect with them there. But it's like you have to use whatever means necessary, or whatever the most low-hanging fruit is, to make those connections. But as a true community health worker form, if they needed step-by-step instructions and repeat attempts, that's exactly what happened to make those connections.
Thanks.
Yes, you're welcome.
Yeah, and in addition, one of our sites that has hosts two of our community health workers works primarily with the older adult population, and understanding that they're going to have that population might have even more difficulties than most in doing virtual outreach or just engaging in virtual programming. They have done some innovative research to figure out what platforms were the easiest for folks to join on to. And then since they were used to doing more like, communal meals in a certain place, but since that moved and they started doing deliveries, home meal delivery, they started putting like handouts that had instructions on how to join their programming on Zoom, that, step by step. And that also listed like the schedules of their programs as well. So, and then provided like a phone number for folks to call for technical assistance as they needed when they were trying to log on. So those are just some of the ways that our community health workers have been trying to navigate those issues. But again, the learning collaboratives have been the perfect avenue for us for the community health workers to share those ideas and innovative ways to overcome those challenges. So
yeah, and along those lines, we've found that some of our organizations have these temporary, what they thought were temporary pivots have become really meaningful pivots and things that they want to continue and make permanent at some point. I'm thinking of one organization in particular where they don't do a lot of outreach events in the winter because of their population as older adults. And so they found that these virtual platforms have been working really well for them. And so they're going to continue with those even once things begin to open up and once it's safe to meet together again. So what kinds of things with your programs and in your organizations have you found that you'll be making permanent changes, as that initially began as something that may have been temporary or you thought would be temporary, but then now it seems like these can become like permanent shifts in your workflows?
Just to piggyback off of what Banita was speaking to about the activities that this organization is going to keep permanent because of their population is the the Zoom platform that they've been using to get the seniors to be active. They do Zoom exercise, and at first they started out maybe 1 or 2 people that were joining these sessions. Now the session group has grown to about 30, and now it's including family members, children, and or whomever is at home with them, and just keeping them active. And really, people just need to be connected to, and they enjoy that somebody is checking in or even thinking about them in the slightest way, because we're all reaching for hope. We're all reaching for that bright star, or that spot that will give us that, something to look forward to. And they're getting that with these different platforms. A lot of groups that were afraid to come together because of the domestic violence stigma, they've been able to also use these virtual platforms to connect with them, provide resources, because they're able to be more intimate with the conversations, and give people an opportunity to even connect with others who are going through some of the same challenges. And when it comes to even documenting that, that was something I know that when we initially started out with, how do we document all these things that we're doing, and how Banita had already expressed that we had to do things really creatively and differently, because now we have all these different nuances of services that we're providing, and then how do we even capture this to be able to adequately analyze the data. So that became a process in itself, to see some of the things that people, the community health workers, were connecting people to, like for those who were going through homelessness or domestic violence, who hadn't had clean clothes, or who hadn't had a haircut. They were referring people to beauty salons to get haircuts, or just ice cream shops to have an ice cream just to lift their day. And those things that we didn't think of initially, but as community health workers, those are things that happen within their organizations quite often. So we had to figure out, how do we capture these things, and Banita and the team, the not data collection, but our analyzers did a great job in pivoting to even capture those nuances, because it mattered. It mattered. I know our funders wanted to see that. They wanted to see actually what was really going on, and is what we're doing making a difference on the ground, where we wanted to see where we really intended to see the impact. So I would say, for those who have their community health workers who are out there trying to figure out, how do we still be effective and impactful, it's like, use every resource that you can, because one of them will be the one that works really well for you, and you can see it as a permanent part of how you go forward with connecting with community members.
I wanted to share. So my name is Rashonda, and one of the things I think we've sort of learned to navigate during this time is, I just have one example. We were hosting these sort of these statewide expos for individuals that were returning from jail and prison. So we were hosting them throughout the state of Illinois in different areas. Some of you might have heard of them. They're called the Summits of Hope. And these were initially in-person events, and they were designed so that folks who were coming out of jail and prison, they would be able to go and get testing, like for HIV, and different resources that they might have needed. They were able to get things like an ID, or just a bunch of different things, essentially like a one-stop shop where you can go from table to table to get the things that you need. But when COVID hit, of course, all of that got canceled. But one of the things that we were super fortunate to do was to move it into a virtual setting, which is very crazy, because they're initially trying to go from table to table to get the resources that they need. But one positive thing that we were able to see from it was, moving it into a virtual setting, more people could potentially have access to it that would otherwise be hindered because they didn't have transportation to get to the location, or they just didn't have the resources, like someone to watch their children and things like that. But now, working, being at home, they have access to it. And even though there are some barriers in terms of what someone mentioned earlier about them not having access to the digital technology, we were also able to work with some of, the Department of Corrections, like the parole officers and things like that, to sort of connect them and make sure that they were able to get a hold of this information. And if they weren't able to do it live, by it being in a virtual format, we were able to record it and then send the recording out later so that they could go back again and again to listen to some of the resources that the speakers released. And we were still able to get just as many speakers from that area to come in and speak about resources like housing and employment and healthcare and things like that. So I think one of the things we're taking from it is the adaptability to be able to shift some things online, even though it's not preferred, but we're still able to shift it and still be able to help the individuals that need it, which in this case, those are our stakeholders. And I've also seen it where our organization, which is PHIMC, if you guys see it on my background, but we were just able to really move all of our stuff in a virtual format, and the impact almost seems like it's greater, because a lot of times when you're working in an office, it's hard to get away because you have so many meetings and things going on. But because it's virtual, we've seen an increase in numbers, and the ability to train providers that are working with individuals in the community has increased. So even though it's crazy times, I think the adaptability, that's one thing sort of we're taking from this, and that we will continue to use is, the adaptability to make things virtual if they need to be.
That's pretty amazing. And I know even for our community health workers, we had to even make sure that they were virtually astute, that they had the things that they needed to be impactful. Technology was something that, had to be at the forefront as well. Even for us that went home, we had to make sure we had the right bandwidth. We had the right laptops. We had the right microphones and things to be able to do the work. But I will say it has allowed us to reach a broader audience and to let people know more about what we're doing as community-based organizations and what we offer. And people are able to take a deeper dive and a deeper look, because now they're in the comforts of their own space and they have time. So, taking advantage of the time people have right now has been really, really great. And being able to share information as well. So kudos though, great job.
I think for us, we have a cancer resource center, which has, with being digital, it allows patients that sometimes don't feel well because of treatment or just recently had surgery to connect when before they wouldn't have connected. So it's allowed us to have that to more come into the home through their digital devices, and then be able to take advantage of community educational programs, exercise classes, short-term counseling, and things like that. So that's really opened up for us in that aspect. And like you just mentioned, opening up geographically to be able to expand a little bit further than what our original service area or group of participants would come to our physical place. So that's been a nice plus, I can definitely say. And I know we were, before then we were talking about this because of the population we served, of going digital and doing something. So COVID did force us and pushed us into this, and realized it was not as scary as we thought it would be. But definitely something that we will keep some type of hybrid schedule as we move forward. So.
We found that with a lot of our programs as well. So I gave the one example of our one program, and Kim gave some others as well, but we found that with the scope and the reach of our community health workers has really increased as a result of their virtual platforms. So a lot of them have talked about keeping that as well. Yeah. And I see we had a comment in the chat to share that original question about what roles do people.
Did you repeat that, Banita? I didn't hear the last part.
Oh, so I'm going to share my screen so people can have an idea of who else is in the room here with us in terms of what roles they have. So can you see that now? Okay, great. Great.
I think one highlight, in addition to, in terms of evaluation for our community health workers, is we have a monthly reporting form where they track their referrals and contacts. And we had to expand that form because it had like an upper limit of the number of people of contacts that you can have for the month. And they were, once we went virtual, the views on the health education videos and COVID, just COVID information videos that some of our community health workers were putting out as on behalf of their organizations were reaching thousands of folks, which we weren't reaching, just on our face-to-face, individual basis. So that was an exciting challenge to have, was to expand that. And they just continue to build partnerships through their virtual outreach, because they're just getting more visibility of their organization and their services. So yeah, they're seeing a lot of benefits from that virtual outreach. Is anyone else seeing some permanent or any innovative changes that you've come across or have already been implementing in your organizations that you're planning on keeping? I know it's Friday and it's election week, so everyone's a little, probably a little fried, but I'm appreciative of the folks who've shared so far.
Absolutely, and I just think it's really great that even people took the time to come to the roundtable, but also to speak, to the learning collaborative piece. Again, when we would get together, it would be just so refreshing to hear how happy the community health workers felt about using these alternative ways and how they've changed or impacted the community still. And they were afraid at first because everything was like an unknown. It's just, what do we do? But actually to take the suggestions that they offered one another about their own best practices that have been happening, and then maybe they wanted to implement them themselves and see them be a positive outcome for how they connected to community was really, really good. And they encouraged each other even through their own challenges and triumphs. So that was really, really great. And I always say, for those who have community health workers or who oversee them or who are even thinking about them, it's really, really great to give your community health workers an opportunity to share and to sort of download about even what they're experiencing, so you can get a feel of how, are they experiencing burnout? Will they be able to handle the role? What's going on? Give them an opportunity to share, and then provide some supports or provide some things that they can use for self-care. Because as a person who's always giving, they forget to think about themselves, and they were going through that really, really hard. Again, especially with the pandemic beginning, they went through that really hard, and they felt guilty actually for not being able to do their work the way that they did. So just in that regard, having those spaces where they can have conversations is really, really good as well. And it's really been a great experience for all organizations involved from my perspective.
And it can be really challenging to meaningfully engage other stakeholders and all stakeholders in an evaluation and in a program in general. Part of that is sometimes the time limitations. It takes a lot of time to get everybody together to be able to collaborate together and to have these conversations and discussions. So curious to hear what, when you've engaged stakeholders and other things, what has been meaningful about that, and how have you found that process?
I saw that we do have a question in the chat. If we want to.
Yeah, if you wanted to pause that question for just a second, I do have one from Mariana here that is, what advice do you have for an organization that wants to look into community health workers? It's a great question.
That is a great question. Kim, do you want to take that?
Well, I can start it, and,
Okay.
and Angela, definitely you can jump in with that. You know, with Sinai Urban Health Institute having 20 years in experience with community health worker and the community health worker model, we've definitely been sought after to train community health workers, to actually seek them out, because it takes a certain type of energy to even do this work. Everybody is not cut out for the role, because you know the empathy level is so high that some just say, okay, this is not the right fit for me. I see Jackie has put in the in the chat box the link to Suhi Crowd and what we offer. But I would say, you know, feel free to make a connection with Sinai Urban Health Institute, and we, with the 20 years of expertise in the field, can give you a very detailed insight on how you can do that. Because again, CHWs cannot be supervised or managed like the regular worker, because their role changes daily. It's not the same situation every day, and times that you spend doing work changes. It ebbs and flows because of what we provide. I like to say we don't provide equality, we provide equity, giving those community members what they need, because everybody doesn't need the same thing, but people need what they need to be successful or to be healthy. So we try to give them that. So I would defer to saying the Suhi website is a great place to begin. And we are there to answer any questions you may have and provide you a little more insight and detail on how you can actually do that. I hope that answered your question.
Yeah, there's so many great resources on that website. So I hope you check it out. And we're only in the second year. We're finishing up the second year of our pilot here. So we're still gathering our lessons learned from our experience in this pilot. So keep an eye out for some forums and exciting events to where we share our lessons learned from our experience in the coming months, and especially in 2021. We're really looking forward to that, because we have had such a wonderful experience. And yeah, we're hoping that we can also, of course, bring in the CHWs themselves to share their stories, because they're the best at, you know, this story is all about them, of course. So we want to be able to allow them to tell their stories themselves too. So. Should we shoot back to your question, Banita, that we skipped over a little bit? Do you want to?
We were talking about some of the what's been challenging about meaningfully engaging others in your efforts, other stakeholders, because it can be a very, very challenging process, as we found, but it's also can be very rewarding. So curious to hear about what's worked well in that process, and also what you've found to be challenging in your own programs and in your own organizations.
Well, again, we have this great time, and at least we can at least talk to one another and just see how we're checking in, because I know that what I found, and I'll just say from our experience, even going through this process, what I found was really helpful was to actually hear stories and hear about the experiences. And even if it did not include an actual interaction with a client or with a patient, but what is it that what are you feeling in this moment? And sometimes when you are able to hear how people are feeling in the moment, you're able to provide them with what they need to get through those moments. And that was again an approach we took for keeping our community health workers engaged, and even providing them the services that they needed to be effective in their role. So again, when we asked about, you know, how are you feeling, and they've said, I'm scared, or they say, I feel like I don't know which way to go or which direction to be in or follow. we were able to, again, be that support, and they were able to lean on each other. And then we also were able to give them tools that they needed to get that care, so they can, again, fortify their confidence and their efficacy, so they can do and help for those that they serve. I realized that a lot of what we did had to be new. It had to be innovative. It had to be out of the box thinking, but it still had to be person centered, and not just going with what we think would work, but what people said that they would need to be effective and to actually keep moving the ball forward. Because COVID happened, the needs didn't stop. Everything kept going on. They kept moving, and things got more intense, and the need actually grew. We had not to only just do the regular stuff, but then we had to add on some mental health stuff. So we had to add on mental health stuff with us, learning a little bit more, having more of those sessions. So when our clients reached out, we knew how to help them, at least in those moments, as we connected them to services. We had to be that interim piece. So it just never stopped, but it allowed us to apply the learning curve to our own self-improvement. And again, being in those collaborative learning sessions or in those communities of practice, we were able to support one another, and we were able to share, and we were able to grow. And at that same time, we were able to make an impact. And then with that, those services are being utilized even across zip codes, because a lot of our programs were zip code specific. But again, the need still went beyond that. And having the virtual platforms that people are using now is allowing people to even get the helps that they need, even if they're not in the zip code service area. And I think that's been a satisfying piece of this process as well, because people need people. And the zip code really should not set the boundary all the time. And having this, the virtual platform has been really, really great in allowing us to stretch the reach, help people. And then at the same time, those community members were saying, you know what, I'm not in the zip code, but my aunt or my uncle is there. Maybe they can, utilize your services. So it's been like a win-win for all who've been partaking in these virtual platforms. So I would say that for those who have been doing this, think of a way to keep it on in a hybrid model, so that if things take a turn, we're ready. We're already ready and prepared to keep the good work going.
Hi, I do have a question. It's more of a general question. Thank you all for having this roundtable. I am coming from the academic side. I'm a researcher. I actually worked with Kim and other CHWs at SUI because we're working to develop a tobacco cessation training for that's tailored for community health workers to deliver. And I've been working on this project for a few years. We've talked with many community health workers in focus groups. We have interviews with community health worker managers, and we've gotten a lot of different information. And so knowing that the community health worker model of care is very variable, it depends on who it is, who you're working with, and thinking about developing something like a training for community health workers, is there like a such thing as a standardized training? And kind of like, I'm just kind of curious your thoughts about, coming up with something, a standardized or one curriculum that will fit a lot of different ways that community health workers reach out to their clients. So I would love to hear anyone's thoughts about that, especially yours, Kim.
Hi, Marsha. Thank you so much. Yeah, that is definitely what we do. It's along the lines for the core skills, which is like the recommendations. And this is done across the state. Some core skill curriculums that community health workers need as a foundation of what they could have in order to be effective in their role. And when it came to things that were disease specific or topics specific, the organization layered on those additional trainings. But what the community health workers got, and most community health workers receive across the states, are the same core skills that are foundational for an effective community health worker. And as I stated before, some of those modules include social support. They include motivational interviewing, goal setting, health outreach, adverse childhood experiences, which gives community health workers insight on why people are who they are in their illnesses, because those things do become a part of them when they are younger, and habits that form, and different things like that. So those 40 hours are well spent, but it is the foundational information that we provide that is a core skills curriculum that CHWs across really the country are across our states are taking part in, and they call it the core skills curriculum, or the C3 recommendations.
Yeah, and Kim and Suhi have been a part of, as well as Health and Medicine, have been partnering with the Illinois Community Health Workers Association to kind of, so back in 2014, there was a bill passed in the Illinois legislature to identify community health workers as a profession. And as part of that, an advisory board was created to bring the Illinois Community Health Workers Association, as well as other stakeholders, to the table to think about what certification could look like possibly for community health workers. And as part of that, there are committees working currently to kind of put together what does core skills look like for the state of Illinois? What would, in terms of having a community health worker certified, what would they need for their foundation in order to be certified? So that's just one piece of policy that's kind of moving forward currently, and there's some exciting movement, especially just due to the pandemic. It's highlighted the need for more community health workers in our health system. People love talking about how the pandemic has identified more of the gaps of our healthcare system, and community health workers are there to fill a lot of those gaps. So we're excited to be a part of those movements and support. And this pilot is a perfect example of how those core skills can move that along. And in reality, like we're seeing how they work well on the ground. So yeah, so hopefully that helps you answer your question. So if you'd like to be a part of that movement, we're always willing to add more people to that advocacy group. So
Thank you.
Great. Well, we're actually rounding out our time here right now. So I just wanted to take a second and say a huge thank you to Angela, to Kim, to Banita. This was really fantastic. The work that all of you are doing is so innovative, being able to combine strategy and empathy to respond to our new world in such a strong way. So hopefully everyone is walking away from here feeling a little inspired and excited to try to implement some of what you've been talking about. So thank you so much. I really appreciate it. I really enjoyed listening to all three of you speak today. So thank you so much. I just wanted to also share a little bit about what's going to be happening next. So we close out here in just a moment. Again, here's all three of your presenters. If you want to jot down any names, you can reach out later. And we have coming up next at 2:10 on this track, we have our oral presentations on health outcomes in diverse populations in Chicago. So some really interesting things that we're going to be talking about there. You're welcome to join us. And if anyone has any last minute questions, I think, oh, thank you. Banita's dropping her email in there. So if you all wanted to reach out, or if there's any questions I can answer for you, let me know. You can go back and check on the track if you'd like to see what else is available. So thank you all so much. Thank you for spending some of your afternoon with us. Again, thank you, Angela, Kim, Banita. This was really great. I really appreciate it.
Thank you for having us.
Thanks so much.
Absolutely. Yeah. Take care, everyone.
Alrighty.
Bye now.
Bye-bye.